A little bit about our presenter today, Bev Woodward, came to us about 4 years ago. Does that sound right?
Three-ish.
Three, 4, yeah. From the Austin, Texas area. She's been in HIV care for her entire career. She's one of those people that just woke up as a woke up as an HIV activist and advocate and really wanted to learn and know as much as she can. And so she is an RN and a study coordinator for the Tennessee Center for AIDS Research, the Clinical Sciences Corps. And then she's also a study coordinator for the AIDS Clinical Trials Unit here at Vanderbilt. Prior to that, she was an RN case manager for us at the Vanderbilt Comprehensive Care Clinic. And she really spent a lot of her time, and it wasn't even her job to do this, but she spent her time really researching tools and ideas of how to retain patients in care, and developed a whole program where she would actually look through all the patients before they came in and try to determine, using all her tools and research, which patients were likely to fall out of care, and then she would contact those patients and develop additional interventions to retain them in care. So she's been just such a wonderful addition to our team, and we're so thrilled that she's here. And she's one of those crazy people that when work is done, she spends her free time looking at studies and researching and really enjoys that. So we really appreciate her, and we're thankful that she's here to tell us a little bit more about the latest research for retention and engagement in care. So thank you, Beth. Appreciate it.
Thanks so much, Jen. That was a very nice introduction. Good morning, everybody. Thanks for joining us, and thanks also for jumping back on when we postponed for the weather. I don't know what to do with 8 inches of snow. Maybe some other people know what to do with that, but I'm happy that it's melting now and that we're all here. And so I want to just do a brief disclaimer. So for those of you who have tried to kind of dive into the research and retention and care over the past few years, might have noticed that there's been this incredible exponential increase in research and knowledge about retention and care over the past 3 to 5 years. That's really awesome. This could easily be a 5-hour presentation. So with that said, this is in no way meant to be absolutely all-encompassing or comprehensive. If I leave out your favorite intervention, I'm sorry. I'm just kind of talking a little bit about big trends in research, new findings, and then some interventions that I've had experience with that I specifically think are doable in kind of a real-world clinical environment. So objectives for today, I'm going to start out just with a tiny bit of why is retention and HIV care important. This used to be a larger chunk of this presentation, but I think that we are all pretty aware now with all the work on the continuum of care, the HIV and AIDS strategy, of why this is really important, and that's a good thing. But I'll touch on health outcomes, HIV transmission. After that, I'm going to talk about challenges, and so this, I think we're all also aware of some of the challenges keeping people retained in care, specifically finding them, reining them in, meeting their often chaotic lives. Challenges here is mostly going to be challenges in methods, design, and defining retention and care. Kind of different definitions, how this is typically measured in research and in public health, kind of what that means in terms of our ability for comparing different studies or different measures of retention, and then limitations. Next, I'm going to talk about kind of who is most affected and who is most at risk for poor retention in care, health disparities, kind of scope of the problem. And then lastly, I'll touch on some solutions, interventions, both kind of at a community and collaborative level, and then also some evidence-based interventions that can be implemented in the clinical setting, and kind of a few examples of sort of how we've tried to make that a reality here at Vanderbilt, and kind of translate them in. So before I start, there's I have this like tradition with my presentations where I always kind of try to do this some things to consider slide. And I'm not advancing it yet because everyone always just starts reading. And I'm too lazy to put in the animation and make it go more slowly. But anyway, so there's a greater context to all of this that I think sometimes is easy for us to forget. Specifically, people who are poorly retained in care are living within this world that may or may not be very different from our world. And this can be such a tedious and frustrating challenge for us that I think sometimes when we do finally find this poorly retained patient, or they're finally in front of us, at least in my own experience, it sometimes takes a lot of control for me not just to shake that person and say, where have you been? You know, we've been looking for you, and oh gosh. And so it's easy to blame people for these problems or to talk about it in a blaming way. And I'm a big fan of kind of backing up and looking at the whole picture. So here's some things to consider. This is not just about remembering appointments or caring about your health, things like that. So the first kind of interesting tidbit is discrimination. In a study of HIV positive Latino men who have sex with men, those who reported being treated differently based on their sexual orientation were less likely to be retained in care. And this was a perception, so felt like people in general, and this wasn't even just at the clinic, they felt like they were being treated differently. This is at the convenience store, maybe. HIV status disclosure and support is something that we cannot escape when we're talking about retention and care. So individuals who report never telling anybody about their HIV status ever have been shown to be twice as likely to be poorly retained in care compared to people who have disclosed their status to somebody else. And then the last kind of piece is that no-shows have real clinical significance. As a nurse, I always get really excited when things like the HIV treatment guidelines get updated to include more kind of non-medical, bigger picture aspects, including things like retention and care. And I get even more excited when the world kind of starts realizing that these aren't separate things. That when we talk about behaviors like keeping appointments, that's not, you know, a soft issue or a softer issue than comparing to hard clinical things like a medical model. Because the bottom line is that no-shows have a clinical significance, and that patients who no-show are straight up at higher risk for mortality, period. So why does retention matter? I hit on a couple of those things. And again, I'm gonna kind of be brief about this because I think we're pretty aware of it. Patients who are poorly retained in care are more likely to have detectable viremia, which is, we know, associated with a whole host of other problems. They're more likely to have prolonged viral burden, which is sort of a long-term measure of cumulative impact of the virus on somebody's body and their life. It's sort of comparable to like pack years for smoking. So people who are poorly retained in care are just more likely to, after years, have a lot more impact of viremia on their body, which now we know plays a big role in inflammation and comorbidities of HIV, pain. So they're less likely to maintain access to ART. This is a big deal. One of the biggest predictors of being on ART is being able to come to the clinic and coming to your appointment. And as I've already mentioned, they're at higher risk of death. And increased mortality risk associated with no-shows and poor retention and care is an independent risk factor. So that's when controlling for all sorts of other things like CD4 count, virus, being on meds, race, age, comorbidities, everything. So because of all of these kind of important issues that have come to light about retention, we've seen an increase in the kind of role that retention and care has played in a lot of big strategies, which is a great thing. So the National HIV and AIDS Strategy now includes retention and care and decreasing racial and health disparities related to retention and other measures. And we've seen that now retention has been incorporated into the HIV treatment guidelines within the past few years. So a few public health kind of reasons that this is important. Individuals who are retained in care are less likely to transmit HIV to somebody else, even when they're not on ART. I love this too, because it's not just about being on meds and suppressing the virus and that affecting transmission, which is also true. But there's just something about being in care that leads to more, I think, positive self-care and positive health behaviors. And improving retention among those that are most affected by poor retention could help lessen health disparities because retention behaviors contribute to these health disparities. So this is also very exciting to me. A recent study, a pretty big study, I'm looking for a number now. Let me see. So a huge analysis, over 10,053 patients who are receiving care at 6 different academic HIV clinics across the country. They looked at the number of no-shows that patients had and then how that was kind of related to viral load and viral load suppression. And they realized that accounting for no-shows significantly reduced the odds of non-suppression among Blacks as well as among IV drug users, which are two groups that experience disproportionately high rates of unsuppressed viremia. And so this, to me, is one of those very exciting kind of findings. Racial disparities and all sorts of other kind of social determinants of health can be very discouraging to think about because they're big issues and you're not sure how to fix them. But if this is something, when we start talking about if we could improve no-show rates and that could help lessen racial disparities in health, that's really cool to me. I mean, I know I'm kind of a public health nerd kind of person, but that's exciting. So again, racial disparities and viral suppression lessen when you fully account for no-shows. So moving on to challenges, specifically in kind of measuring and talking about this, kind of like setting ground rules. So the bottom line is that retention is incredibly complex. It's difficult to define and it's really hard to measure. There really is no gold standard for how we're defining and measuring. And so one of the results is that lots of different studies might do it in lots of different ways. So one issue is that it's fluid versus static, which is one of the cons of kind of the adopted kind of HIV care continuum or cascade, is that it has these very still and fixed points, these bars, that go down and they keep getting smaller. But they're not moving around, which I know that you don't usually make a table or a chart that's moving around. But if anything in this world is moving around, it's retention and care. What I mean by that is this thing called churn, which is basically kind of a measure of, or this phenomena of at any given time, you've got people moving into care, reestablishing care, falling out of care, maybe falling out of care and not receiving care for a little while, or maybe the next day establishing care in another state, but we don't know that because we're not talking to that state and we're not measuring it. And so you might have this core group of stable patients that are living in the same place for several years and are staying in care. But the much harder thing to measure, and the thing that is still often not measured, are kind of these other people that are really driving it. And so currently there are multiple definitions of retention and care. There's missed visits, which typically can be measured in one of two ways. One is, just a yes/no visit over a certain amount of time. Did this person have any no-shows? Usually with missed visits, people don't count canceled appointments in that. That's not considered missed. This is just no-shows. Another way you can measure this and compare differences between groups is differences in the actual number of no-shows that different people have over time. There's visit constancy, which is time intervals with at least one visit in a specific amount of time. I think we're those of us in the kind of Ryan White world are pretty familiar with kind of HAB measures, at least one medical visit in each 6-month period within a 24-month period, at least 2 months apart. That's a great example of kind of a visit constancy measure that's dictating policy and funding. There's gaps in care. This is typically the number of 6-month intervals that contain no appointments that people have. Visit adherence is a proportion, a rate, so it's the proportion of kept visits over the total number of scheduled visits. And so this is really important to talk about all of these different measures, because when we just say retention, I could be meaning any of these things. And if I look at one state's continuum or one study on retention, that doesn't necessarily mean that I can compare those results to another study very easily at all, because they might be measuring them in totally different ways. So some nice studies have come out looking at how well different measures agree with one another to try to figure out, well, are we actually measuring all these different things? And the good news is that they don't seem to be totally far off from one another. They correlate well, they're related, but they're not exactly the same. And so it's just kind of something to keep in mind. Limitations and considerations, I've already hit on this a little bit. There's a lot of movement in this problem inherently. Measures and endpoints, kind of how we're defining things, how much data we're collecting, how well we're able to see trends over time. Data origin is a really big deal. One of the great things about retention and care is that we've got the possibility to measure retention in a way by looking at lab values that are mandatory reported in different states. So CD4 and viral load. So for a lot of studies, surveillance data is used and a lab data is used kind of as a proxy. So the assumption is if labs were drawn, this patient was seen by a provider. I think those of us who work closely in the clinical world know that there are a lot of different reasons that labs might be drawn and the patient was never seen by a provider. We have a lot of initial visits here who the patient will see a social worker or an intake coordinator, get labs drawn and never come back to their first medical appointment. Those people aren't retained in care, they never even establish care. And so on one hand, we don't want to throw out surveillance data. It's hugely important and we can learn a lot from it. But a recent study has also shown that in comparing how well lab measures work as a surrogate for clinical encounters, again, they're kind of similar. They're not totally far off, but we're missing something. It's an imperfect match. And so improving kind of data measurement is a big deal. We've got the population captured. It's really, really hard to count or measure something when you can't find it. It's kind of the basic bottom line of that. Comparison, which I already mentioned, and then evolving treatment recommendations. So in the past, we might have looked at gaps in care or 6-month periods that didn't involve an appointment. That's different now that guidelines are changing and really stable patients are not necessarily needing to be seen any more than once or twice a year. We're gonna have to change measures of retention and research, and that's gonna further limit, I think, certain comparison in the end. So next up, who is affected? I think this is what we're probably most excited to talk about, in the interventions. So here I'll talk about scope, kind of impact of the problem, risk factors. So there's a lot out there about retention, how many people are retained in care. I'm not specifically going to talk about any particular continuum in this because that's not the point of the conversation. But one is that we know that this is a big problem, kind of no matter how you slice it, no matter how you measure it, no matter how you count it, it's a problem. So a meta-analysis of multiple different studies on retention found that only 69% of individuals included had 2 or more visits during 6-month intervals. So again, this is a good example of that means something different and will mean something different in 2 years compared to maybe 4 years ago in terms of frequency of how long or how often people need to be seen. And then great data from the NA Accord, which for those of you who don't know is just this awesome kind of gold mine wealth of data, clinical data, that describes a population of people living with HIV, which is generally thought to be representative of the entire HIV population in the United States and Canada. And so data from the NA Accord recently showed that 25% of individuals who accessed care during an 8-year period from 2000 to 2008 had 1 or more out-of-care episodes. And this specifically was looking at a huge group of patients, over 61,000 folks who are accessing care all over the country. Good news is that recent studies, also with NA Accord data, have shown that there's improved trends over time across the nation. So throughout the nation, this is kind of getting better and has maybe over the past 10 years. With that said, we still have a lot of work to do in the South, which I will get to. So poor engagement among our new patients, just a little bit about that. I think those of us in the clinical world have seen this as well. It's not so much a surprise, but a kind of a smaller study of newly diagnosed patients from 2004 to 2011 found that at least 63% had a gap in care at least once. And a gap in care, again, is typically 6 months or so without. And kind of a disheartening tidbit about this is that prior gaps were associated with subsequent gaps. This trend has also been echoed in NA Accord data, huge data sets of over 61,000 people that show that there's a high level of individual correlation between people's retention patterns. So unfortunately, when we're looking at somebody who's poorly retained in care today, there's a high chance that they might be poorly retained in care in a few months too, because these are patterns, they're not singular events. So second, a study using the 1917 clinic cohort found that 60% of new patients missed a visit during the first year of care. That's a huge statistic. And these patients also had a higher mortality risk. So I want to shift a little bit to talk about geographic and regional differences. Just as distribution of disease differs geographically, rates of retention vary by region as well. And I think this is really important to talk about, especially when we start talking about interventions, because different populations are going to require different interventions. I think it's an incredibly important task for us to be able to look at interventions and demand that they have proven efficacy with our people in the South, because this is kind of a different bunch. So this, and I'm sorry for the people who are in this room with this tiny font, this map is actually not a map of retention and care. This is a map just of HIV prevalence in 2012 across the country. So the darker colors are higher prevalence of HIV, the lighter colors are less prevalence of people just living with HIV in the country. So you can see higher burden of disease in the South and the West. Most recent study looking at these geographic differences from NAA Cord show that the chances of being poorly retained are higher for people living in the South and the West. So this could be a map of retention and care as well, looking at that burden of disease. Interestingly, the same study with NAA Cord found that there are kind of some possibly slower improvements in closing gaps between racial disparities of health, and maybe even less improvement between our patients who are Black and our patients who are white in terms of achieving retention and care and viral suppression. So just a few kind of things to think about. One thing that I want to say is that I want to be very clear that I'm not at all saying that an increased prevalence of HIV is directly related to anything like poverty, level of education, or race. It's a much bigger picture than that. But what I'm saying is that we live in a special place with a unique set of challenges, and we need to be able to see this whole picture. So here are two other maps, kind of looking, again, remember, higher risk of poor retention and care for the South and the West. The one on the left is the same one we were just looking at, which is simply just the prevalence of HIV diagnosis in 2012. And then the one on the right is the percentage of the population living in poverty in 2012. So you can see that there are some very similar patterns. The poverty map, the darker colors, the darker blue, indicate higher rates of poverty. The last one, again, same thing, HIV prevalence on one side. On the other side is the percentage of population with a high school education, at least a high school education in 2012. And this one, the colors are kind of opposite. The lighter colors indicate less percentage of people. So the very, very lightest is 0 to 79% have a high school education or below. So you can see that still, though, there are these kind of color patterns that match, that go together. For those of you who haven't looked at AIDS View, that's where these maps come from. It's supported by Emory University, and it's really awesome. One of the things, though, that I get really excited about when we start talking about retention, especially interventions, and we talk about racial disparities in the South, the importance of finding interventions that are going to work for us, is that I'm very proud to say that we have in the South some of the most brightest minds and greatest retention experts living within our region, within these states. And so we're in very good hands. And that's an exciting thing too, because I know that a lot of people are studying this kind of through the lens of where we are. A little more on social disparities of health. So risk for poor retention is not equally distributed, just as I showed you on the map. It disproportionately affects Black patients versus white patients, young patients versus older patients. There are some differences based on HIV risk factor. So men who have sex with women typically are less likely to be adequately retained in care compared to men who have sex with men, as are IV drug users. Substance abuse is kind of a different issue, but there are some risks there as well. Neighborhoods, people have looked at this in different cities at zip codes. And then even quality of life. So patients, a recent study showed that patients who are in pain, who are not abusing substances, are less likely to come to their appointments, are more likely to no-show basically, compared to patients who didn't have pain. So I feel like any kind of, on some level, any discussion of HIV still, without really taking a moment to talk very specifically about stigma, is incomplete. And hopefully, that won't always be the case. But I think it's telling that, the reason that I always put this poster on this slide is this was an early poster from the 80s. And I think that there's still a need for this kind of poster in a lot of our clinics. So this is directly related to stigma and social support. Great study from Birmingham from the 1917 clinic cohort found that patients who reported never disclosing their status to another person were twice as likely to be poorly retaining care. Interestingly, they also looked at differences. Does it matter? Do you get this exponential increase with more people you tell? And they found that there really weren't any differences between people who had told just one person or one group of people, like family, compared to people who might kind of be out completely about HIV and they're activists and they're identifying as an HIV positive person publicly, that basically just being able to talk with one person about this had a protective factor in terms of being able to be retaining care. Again, all of this is important because when you're not retaining care, you have an increased mortality risk. One no-show increases your mortality risk. If you can increase or decrease your no-shows by helping someone appropriately disclose their HIV status to somebody, that's a really big deal. That's a win-win. So in the same study, poor retention and care was also independently associated with living alone. So patients who lived alone were less likely to be retained in care. A smaller study has linked increased internalized stigma to gaps in care. So this was, again, looking at gaps in care of 6 months or more. Measures of internalized stigma, which is typically kind of how a person is feeling about themselves and how they're maybe stigmatizing themselves. And they found that a direct correlation between increases on a scale of internalized stigma and gaps in care, not being able to come to their appointments. Another study kind of from the South, Atlanta, Georgia, patients who always attended appointments reported knowing somebody else who was HIV positive. Again, patients who weren't coming to appointments were more likely to report not telling anybody. And I know this is a huge deal, and I don't want to minimize how important it is to really speak thoughtfully and deliberately about status disclosure. Because for many of our patients, for most of our patients, there are very real and perceived risks of disclosing your status. People still lose their jobs, people still encounter violence, people still lose their families when they disclose their status. And so it's a tricky thing. But I think that there's a lot of evidence now, or an increasing amount of evidence, that if we can find ways to best support our patients in just even identifying one person that is a safe person to tell, that could be a protective factor. So now I'm going to kind of move into solutions, and I'm going to kind of talk about these in two broad kind of different ways. The first, a little bit kind of on the population level, mostly collaborations between public health and academic research. Just a little bit about what a few things we're doing here in Tennessee, a little bit through the Center for AIDS Research that I think is exciting. And then I'll move on to the individual level interventions that can be implemented in a clinic, and then kind of a little bit of firsthand examples of how we've tried to do that at Vanderbilt. So the first step, so partnerships and collaborations. One thing that I think is so important to talk about when we're talking about solutions or interventions for retention and care is that just as we were talking about churn earlier, and that if any problem is a fluid problem, it's this problem. This is not a problem that we can fix by sitting still. And nor is it a problem that we can fix by sitting in our own office in a silo of information. More than ever, I think this demands multidisciplinary work and kind of innovative and novel collaborations between organizations that historically might not have really worked that well together, like public health departments and academic research institutions. And there are barriers to break down. It's not easy. But one example of kind of how people in Tennessee have been trying to do this is that our Tennessee CFAR Clinical Sciences Corps, it's taken me a while to explain the Tennessee CFAR without saying the words threesome or three-way. So now I'm saying triad. It's between the Tennessee State Department of Health, Meharry Medical College, which is local medical college here in Asheville that is very well renowned for studying disparities in health and minority health issues, and then Vanderbilt University Medical Center. And one of the projects that I think is really great is this continuum of care working group that we have. So kind of stakeholders and groups from all of these organizations, not just epidemiologists who are on faculty at Vanderbilt, but state epidemiologists who are analyzing surveillance data all day for their job. Also some community workers, engagement with AIDS service organizations, get together regularly, and not just to talk or lecture, but really to be active and to think about things to do, to make little task forces, to join forces in analyzing and interpreting surveillance data in novel ways that hasn't been able to be done before, and to even just have writing groups get ready to kind of joint write submissions and abstracts for conferences and other proceedings. And I think this is, in a lot of ways, really revolutionary. When I worked in Texas, as in many states, there was a long history of kind of unfortunate miscommunication between even public health clinics and places like DIS, the Disease Investigative Specialists, or public health surveillance. There was a lot of misunderstanding, a lot of quarantining of information that led, unfortunately, and it was unintended, but led to treatment delays for certain patients, especially with infectious diseases like syphilis or something like that, because people just weren't picking up the phone and talking a lot about it. So I think this is really great. So this is just one quick example of something that has been possible from this. I stole this from Peter Ribeiro's presentation in November. He's in the working group. So they've also been able to make really nuanced and very detailed and specific HIV care continuums for Tennessee, which is great. I just included the little slide about retention for this one, since that's the point of the chalk. So that's a bit about what we're doing here kind of on a community level. Evidence-based interventions that are kind of implemented in the clinic is next. So all of these links are at the end of my presentation, and I talked about this last year too. A great thing that the CDC is now doing is, I think, having a much more active role in getting materials and instructions and resources out about evidence-based interventions for retention and care for HIV. And this is something that's also in a way revolutionary, because there's a long history of quarantining of this kind of information within academic institutions. So for a long time, in order to read a lot about evidence-based interventions, you had to have a membership to the library of an academic institution. You can't really just sign up for that. You kind of have to work there or be in school, typically. And so there's been a big movement to try to get some of this in a more public space online and have resources that are free for people to use. And so if you haven't been to this website before, I encourage you to look at it. The link's at the end, because there's just a lot of very practical information. You can contact the interventionists or the designers of different interventions to ask them questions. It's creating a space for collaboration and networking, which is important. So this is one of my favorite interventions that's on this website. Enhanced personal contact is, I think, kind of what it technically was called. And I talked about it last year, but there's been a lot of updated information about it now. So one of the reasons that I love this intervention is that the first time I read it, I thought that's very doable. The main premise is that if we increase this personal focus contact that we have with patients between appointments and at appointments, and kind of keep following up with them, that they will be more likely to be retained in care. And it's important to note that this wasn't the kind of intervention, which, yes, are also very effective, things like motivational interviewing, cognitive behavioral counseling, strengths-based case management, all of those things are great, but those are very resource-intensive interventions. They need a trained person, often a nurse or a licensed clinical social worker, and they need hours of time, often, to really get a good session in. And so this is 10 minutes here or there, and I feel like it's very practical. So the original study looked at 1,838 patients across multiple sites. It was a randomized controlled trial, and so they had 2 intervention arms and then 1 control group. The control group, sites who ended up in that pot, it was standard of care. So all the sites had an existing system for just general reminder calls, automated, or somebody calls and reminds the patient before the appointment the day before. So that was the control, what's typically happening. The other 2 both included this enhanced personal contact model, and then one of them they threw on a little bit of extra skill building, the nod to the strengths-based case management, motivational interviewing. So we'll be even better if we throw on a little bit more of these cognitive behavioral factors. It was a 12-month intervention. The outcomes that they looked at were visit constancy, which was at least 1 kept visit within 3 consecutive 4-month periods, and then annual visit adherence, which again is that rate, the number of kept appointments divided by the number of scheduled appointments. Population were patients with a history of missed visits, and then all new patients. They wanted to get them right out of the gate. So I already talked a little bit about the intervention in terms of kind of who was implementing it. But the main thing was that there was first a brief face-to-face meeting at their first visit. That same person, continuity of care, provider constancy, these are things that we know are good, met with the patient very briefly at each HIV appointment, and it didn't necessarily have to be an RN case manager, though I love RN case managers, or anybody with a lot of health professional training. It's just the same person. It's like a buddy system. Then there's a phone call halfway between scheduled appointments. There's a reminder call 7 days before the appointment, a reminder call 2 days before the appointment, and then a no-show call, crucially, within 24 hours of the no-show. So maybe you need somebody who's very obsessive with their Outlook calendar as well. But developing systems to make this work for you is kind of another issue, but there are plenty out there. So results, the first study, which is the one that I just described, found that there was increased visit constancy, so people had more continually engaged encounters and care at the sites who got this, and increased visit adherence, which basically means fewer no-shows, which is awesome. The only kind of limitation to that was that they noticed that patients who were kind of at higher risk, so either with active substance abuse or unmet needs like housing problems, didn't get kind of a benefit of the intervention. So for that reason, the second study, which just came out in the past couple months, actually maybe this month, looked to try to find a little bit more about that. What was going on with these higher risk patients? And I was so relieved when I read this study, partially for self-serving reasons, because it echoed a lot of the challenges that we've experienced in the CCC and that I experienced with the program that I had started. So specifically, they looked at intervening with patients who were high risk. So either mental health, they had scales of depression, anxiety, mental health diagnoses, active substance abuse, or heavy drinking, which was at least 5 drinks. I'm not even going to quote it, because I don't have it in front of me. Heavy drinking, but even heavier than what a lot of us think of as heavy drinking. And so one issue is that they found really the challenges in reaching these high-risk patients. So all in all, the patients who were high risk weren't more likely to be retained in care who got the intervention compared to kind of a lower risk group. However, when you parceled out the ones who got an adequate dose, quote unquote, of the intervention, they did better. And there was no difference in frequency, but basically, just as we've seen here, these people are really hard to find, especially when you're sitting in a room and when you're trying to reach out and call them on the phone. You might make 50 calls a day and reach through to 1 or 2. And so there's a lot of talk in kind of the newer study about what that means, and it's positive to see that once you kind of broke it down by how much of the intervention people got, they did better. But this is a huge challenge because a lot of the patient population that's driving the churn and that's driving the poorly engaged group of people are a higher risk group of folks. So importantly, a separate cost analysis showed that this could be implemented at a low cost, and it can result in financial benefits based on improved attendance, which is what I think everybody who wants to hear, especially when a lot of interventions that we've seen in the past are really expensive and resource intensive and difficult actually to implement in the real world, regardless of how awesome they may be. The next kind of intervention that I wanted to kind of give a shout out to by the same group, also all of these are tested and approved in the South, I want to say. This is another awesome and great kind of idea and innovation because it is super low budget and innovative. So all of these are available online as well. So the Stay Connected campaign was just a clinic-wide messaging campaign. Posters that were consistent, brochures that were consistent, they had the same messages. For those of you who can't see it, it says, "Together we can make a deep difference. Keep all your clinic appointments, your health depends on it." A few different messages, but all similar, specifically talking about the health benefits of staying in care. Importantly, this was also paired with consistent messaging that was given by staff at the clinic. And I think just as important, again, we're not talking about an hour-long counseling session, motivational interviewing, or skill building. These are like one-liners. So the patient would come in and the person says, "Hey, great to see you, so glad you're here. Did you know that by being here, you're taking care of your health and you're less likely to get sick because you came to your appointment?" Done. That is the message. And it was consistent, given by nurses, by providers, by social workers, kind of by everybody. Again, this was a multi-site intervention, randomized with a control group that didn't get it. It was studied at 6 different HIV clinics across the country. They found that it improved attendance to the next 2 future appointments, so decreased no-show rates. It was especially effective among patients with detectable viral load, which is awesome. And again, in another analysis, was found to lower financial risk and improve revenue for the clinic. So all of these resources are available online. So we actually implement kind of a version of this here at Vanderbilt at our clinic, at the Comprehensive Care Clinic. So don't know whether I should say this, but as at many institutions, including Vanderbilt, and there's a good reason for policies like this, it's hard to just hang some art on the wall because these might have to be approved, or you might have to get permission or use stock art. And so we wanted to kind of do 2 birds with 1 stone. And so we got some grant money and kind of modified these posters. We fully cited all of the studies and HRSA and the CDC and everyone involved. But we just kind of made them colorful. We kept the same messages because these messages have been shown to work. And we had a vote. The clinicians picked them. One went up in every exam room and you could pick which one you wanted. We framed them in nice frames. So we got a little bit of extra money to do this, but it was still very, quote unquote, low budget. And all of the original material was available online that we could kind of use as inspiration. So we're not measuring any outcomes associated with this, but we've implemented it. I think this slide was actually supposed to be a little further up in the presentation, but just a few things about healthcare systems and providers, and especially it dovetails nicely from that enhanced personal contact and the constancy, which I mentioned earlier. So patient-provider relationships can't be underestimated in this, and a recent study came out that measured with 2 different measures of trust in physicians and trust in the healthcare system, and measured at multiple times over 18 months with patients engaging in care, found clearly that patients that indicated a higher trust in their provider were more likely to be retained in care. And the same thing with provider constancy. I mean, a lot of professions, including nursing, have been saying this for a long time: continuity of care. This is important, relationships, but this is also true here in HIV. So in a study of HIV positive IV drug users, nice big longitudinal study, years and years of kind of how they were retained in care. The only protective factor that they found associated with retention in care was provider constancy. And I think that's a powerful kind of message. So as I've mentioned, the treatment guidelines have changed. Everything's being updated to kind of more fully and appropriately account for retention in care, and to recommend identifying high-risk patients, monitoring, intervening, without a lot of strict guidance on kind of how to do that. And it's really hard to figure out how to target people in our kind of real world, which I've mentioned, because it's hard to sort of assess interventions for feasibility sometimes as well. So a few things that we've done at Vanderbilt that I think have been useful, even just to learn more about our resources and how we can help kind of tackle this problem. The first was that we started a partnership with the public health department, but more on a one-on-one individual level rather than the collaboration that I was talking about with the CFAR earlier. So the CCC is the Comprehensive Care Clinic. That's Vanderbilt's HIV clinic. We struck up a partnership with the CAPAS DIS, the Disease Investigative Specialist in our area. So the CAPAS project, which the website is right down here at the bottom, is a CDC-funded project that supports states in heavily hit, high-burden areas of HIV. Tennessee is one of them. And they have just really great DIS workers that work for the health department. They're in the field, they're finding people. Their job is to find people and bring them back in, and they are very good at it. And they have a host of incredible resources, including some super snazzy computer software that helps find people, kind of like the stuff that like PIs use, which is cool. So we started first kind of just by facilitating regular meetings between an RN case manager and a CAPAS DIS worker. It was the same worker every time, Veronica Calvin. She's awesome. So are all the other ones, but I know Veronica. This helped us make direct referrals, the results, to the CAPAS program, and then allowed us to have ongoing follow-up every month or every other month. So patients are eligible for CAPAS if they haven't seen a provider in 1 year, HIV provider. Another great thing was this facilitated face-to-face meeting. I think that's important. I wouldn't ever change anything about this program or the face-to-face piece. I don't think this works as well on the phone or faxing over a referral. We got together and we talked about it, and we followed up on a group of very chaotic patients. And there was a designated contact person on both sides. Veronica knew who to call and still does, Leslie Modena, who's in the room, and vice versa. It also helped us develop a clear plan, including referral to our clinic, and if a social worker was needed, we could designate that person, and we just kind of covered all of our bases. So to date, we've been doing this for about 18 months-ish, give or take. To date, we've identified 76 patients as being lost to care. Most of these patients were identified through screening for risk, which I'm going to touch on briefly at the end. And in this time, we've referred 60 of these to CAPAS. And I'll say why we haven't done the other ones. Apologies for the tiny font on there. So of all the patients that we identified as lost, so they hadn't had an appointment with a provider in at least a year, this includes all the ones that we referred and didn't refer to CAPAS. So 46% of them are now re-engaging in care at the CCC, which I think is a really great number. 28% of them are still lost. We've been looking and looking and looking. DIS has been chasing zip codes and going to all sorts of different places in the field. We're talking to family, we're following hospitals, we're following the trail, still can't find them. 11% of them are in care somewhere else. So a great thing about working with CAPAS is we were able to confirm this. A lot of times you don't know, because of churn and because of this high rate of transfer with our population, they may not come back. And when do you stop putting your resources into trying to find them? Well, often, as is the case with these, we realized, oh, actually they have a new provider and it's in another state. 8% of them were in jail and they were receiving care there. So this was a long-term incarceration. 5% of them died, and we hadn't known about most of those, so that was really important for us. Only one out of all these is steadfastly declining care, and it has not been without a fight from Veronica, who's been there talking to him at his house. and it's his choice, and then 1 is on the wait list for referral. So of all the patients we identified as lost to care, 79% of them, the big Pac-Man face, those are the ones that we referred. Real quick, I'm going to talk about the ones that we didn't refer, because I think it says some interesting things a little bit about churn. And again, these are not nuanced analyses. I pulled the data last night, and just so sorry again for kind of the crude graphs. So out of these that we didn't refer, 4% of them just came back in on their own, just showed up, and they hadn't been in care. Perfect example of chaotic churn, of just, hey, here I am. 13% of them we got back in care before we had a chance to refer while they were on the wait list or something like that, usually kind of from our high-risk program. 2% died. 1 of them transferred care, we found out a little later, and then 1 on the wait list. And then of the ones that we referred to CAPAS, 22 are re-engaging in care at the CCC. This absolutely would not be possible and would not happen without Veronica. She brings them to their appointments. She sticks with them for at least 3 months after they're re-engaging. And it's just this invaluable, incredible resource. This also speaks to kind of my idea about our inability to fix this problem if we don't leave our offices and start talking to one another and work together, or if we stay still. And we all play a different role in that, because our job as clinicians and in the clinic is to stay home, is to stay here and, guard the fort and be ready for them when they're brought back in, and to create a space for them to return to. But we need to partner with people who are really awesome at getting out there and finding them when they're not here. So 21 of them are still lost. We can't find them. 6 of them are incarcerated. That's 10%. Again, we didn't know that until we could really confirm it with her. 3 of them had died, and then our 1 guy who's declining care. This is the same 1 guy every time. We don't have multiple ones who are declining care. So the last piece that I'm going to wrap up with was another kind of project that we tried to, that Jen mentioned at the beginning, our kind of screening process for doing risk assessments for patients falling out of care. And this also kind of worked closely with the CAPAS program, because most of the patients that we referred to CAPAS, we realized were out of care through this kind of process. So basically, we wanted to try to set up a process where we could assess each patient as they were coming in, if they had a viral load over 200, for their risk for kind of falling out of care, or their risk for what actually started was for virologic failure. So we found a tool, first developed by Robbins, that uses 7 risk factors to basically generate a score that can help predict patients' risk for virologic failure in the next 12 months. So we started there. Later, we showed with our study that this same scale also highlighted a group of patients that were at way increased odds of no showing for their next future appointment. So our patients who were termed high risk, who met at least 4 of these criteria, were 10 times more likely to no-show their next appointment compared to the patients that were low risk. So it was kind of awesome, because we were like, well, maybe we can just use this to target the people we need to target. This is just a very quick, this is a screening tool and kind of operational definitions there. Pros, what I call population triage. We started out with a panel of 3,000 patients. We whittled them down to about 250 that we felt like, based on evidence from where we got this tool, would be a good place to focus our energy. It also helped develop our CAPAS partnership, as I mentioned, and it helped us just kind of, maybe just me, but learn a little bit more, appreciate a little bit more about our own appointment patterns within our clinic and kind of what's going on in a very real way. Again, these patients were 10 times more likely to no-show. Limitations in a messy observational world. We worked on a program evaluation recently, and our patients who were the high-risk patients, who were kind of enrolled in an intervention similar to the enhanced personal contact, very close watching, getting them back in, they were not more likely to be retained in care or to be virally suppressed compared to not high-risk patients. Again, this is one reason that I was almost selfishly relieved when I read the results of the most recent study on high-risk patients with the enhanced personal contact, because it's very similar. We had a very, very hard time getting a dose to any of these patients because they were incredibly hard to find. I think if I remember right, only about 20% of our phone calls at any given moment were completed with trying to reach this group. So it's hard to measure. We're not sure if the intervention worked. Wasn't a control group. And this sometimes is what happens when you target a very extreme group of people. There are a lot of confounders that you have to deal with. So I think, we've got plans in the mix for maybe using the tool in another way or thinking about other ways we could keep up this kind of population triage. But from my experience, it was something that just sort of helped make sense of this large, often vague world of we should monitor retention and care. And so it was a tangible tool that kind of worked for us, I think. Here are some resources on the web. The first one is the CDC Compendium of Effective Interventions, which is where I pulled the Stay Connected, Enhanced Personal Contact. There are a host of other ones on there, including the ARTIS model or strength-based case management. There's a lot of great information there. And that's all. Thank you. 8:59.